we are approaching our final phase of your caregiver classroom training, and we are going to watch a 20-minute video on different transferring techniques.
The following video will demonstrate the techniques outlined in your training packet. Please follow along in your packet and take notes as needed. Please bring your packet and your completed pre-tests to go over with a therapist during your transfer training class.
Transfer training classes happen during in-services with physical therapy from home health agencies. You'll be notified when these classes are available.
So when preparing to transfer a patient from wheelchair to bed, there are a few things that you can keep in mind about the wheelchair. First of all, the leg rests are removable. So if you turn a leg rest and it's a little bit too close to the bed and you find that it's going to be in your way, before you get the chair that close, you can simply lift up and remove that footrest. So again, on this side, you're just pushing on the knob in the back, turning the footrest, and lifting off to remove. You then want to position your wheelchair close to the bed so that it's either right up against the bed or on an angle, depending on the type of transfer that you're doing. You then want to lock your brakes to ensure patient safety, and you can remove an armrest to make the transfer a little bit easier. To do this, you just pull back on this knob in front here and simply lift the armrest to move it out of the way. Your wheelchair is then set for a patient transfer. I'm now going to teach you how to put a gait belt on a patient. The first thing you want to do is remember that the tag goes on the inside. You then want to put this end through the teeth side first, bring it through the other end, and pull tight. I'll now demonstrate how to put it on a patient. You want to put the gait belt as low as possible. If the patient has tubes or lines or any other medical concerns in the abdominal region, you can place the gait belt higher up. You want to cinch the gait belt as tight as you can to the point where you can only put 2 fingers in the gait belt. You can then tuck the rest of the belt into the gait belt to avoid loose ends. When assisting a patient with a halo, you want to be sure to get the patient into a long sitting position before elevating the head of the bed. This will prevent the halo from getting caught in the sheets on the way up and disconnecting from the patient's head. To do so, we'll simply put an arm underneath the patient's shoulders and raise the patient up. You can ask the patient to assist if he or she has the trunk control to do so. Make sure that when you pull the patient up, you're not pulling on the wires of the halo. You can then elevate the bed, and if the patient doesn't have the trunk control and you don't have the strength to maintain the patient in this upright position, you can ask for another person's assistance. You will then use the same technique when lowering the patient. When working with a patient with hip precautions, it's important to remember that the patient is not allowed to bend the hip past 90 degrees, cross the leg past midline, or twist their body. And so when you're performing bed mobility, you want to be sure that the patient is rolling towards their non-operative side, and you're using an abduction wedge between the legs or multiple pillows to avoid that leg crossing midline. Amy will now demonstrate. When working with a patient with hip precautions, you want to be sure to raise the bed up before getting the patient out of bed to ensure that the patient will not be bending the hip past 90 degrees. You want to, if at all possible, be sure that the patient is entering and exiting the bed on their operative side. Amy will demonstrate why this is important. As you can see, Amy keeps her leg in an abducted position and she moves her trunk with the rest of her body so that she's not twisting. Then when she's seated at the edge of the bed, her hip is not going beyond 90 degrees.
When positioning a patient with hemiparesis, there's a couple things to keep in mind. You want to make sure that their upper extremity is extended and elevated on top of the pillow. It's also important to make sure that their hand is open. In regards to their leg, you want to make sure that it is extended and in neutral. If the physician's orders call for any daytime or nighttime splints or bracing, please apply these accordingly. When performing bed mobility or transfers with these patients, it's important to keep in mind where their weak arm or leg is positioned. When helping a patient roll in bed, you want to raise the bed so it's at an adequate height and you can practice good body mechanics. From this point, you want the patient to bend the opposite knee. If they're unable to, you can assist. You want them to look towards the direction which they're rolling, and with the opposite arm, reach towards the direction which they're rolling. At this point, you may place one hand under the patient's hip and one hand at the shoulder blade to help the patient roll. If they're not able to bend at the knee, an alternate technique would be to have them cross at the ankles and then perform the same technique. It's important to remember any precautions that these patients may have before getting them into any of these positions.
When you're working with a patient who's had spinal surgery, they may be put on spinal precautions to include no bending, lifting, or twisting. Therefore, when you're performing bed mobility with this patient, you want to be sure to use a log roll technique to ensure that the patient's body moves as one single unit. To demonstrate that, you're going to have the patient roll towards you, making sure that the trunk and hips move as one single unit. To get the patient into a sitting position, you're going to reach up underneath the patient's shoulder to get on their upper back and wrap your other arm underneath the patient's legs and get the patient into a seated position as one unit. To return the patient back to supine, you'll use the same technique but go in reverse. If the patient's level of dependence puts you or the patient at risk for safety concerns, you can use the head of the bed elevation to assist you. So for this, you will manage the patient's legs and push the button to raise the head of the bed while lowering the patient's legs. This way, the patient's body is still moving as one unit. Once the head of the bed is elevated to a position where you feel like you can assist the patient, you'll reach around to that upper back and finish to get the patient into sitting. With these techniques, you want to remember to have the patient assist you as much as possible. When working with a patient with sternal precautions, it's important to remember that they're not allowed to push or pull, open up the chest, or lift anything greater than 10 pounds. So if a patient is unable to stand without using their hands, you can have the patient place their hands next to them and use the hands to assist in standing up without pushing forcefully. You can use momentum to help get the patient up. So on the count of 3, rock forward. 1, 2, 3. And then the patient will transition to the wheelchair, and without reaching back, the patient will sit down. It's important to remember that when standing up from the wheelchair, the patient shouldn't be reaching their arms back to push up.
If the patient is non-weight bearing, it is imperative that they do not bear any weight through the involved lower extremity. There's two ways to transfer these patients. The first way is a modified stand pivot transfer. The patient should perform this transfer with the involved lower extremity extended so that it is off of the ground. Good. Becky will now transfer back to the bed using the same modified stand pivot technique. The second way would be to perform a stand pivot technique using a walker. Becky will now demonstrate the stand pivot technique, keeping the lower extremity that's involved off of the ground. If a patient is toe-touch weight-bearing, they are able to use their lower extremity in contact with the ground as a balance point only. They are not to put any pressure or weight through this leg. To perform a transfer, they would use one of the same two techniques, either a modified stand pivot transfer, as Becky will now demonstrate. She is using the left lower extremity only as a balance point, not putting any weight through it. Back to the bed. Or a stand pivot transfer using a walker, again, putting no weight through the involved lower extremity, simply using it as a balance point. When performing transfers with a patient, you want to be sure that you're aware of all precautions as listed in the physician orders. You also want to make sure that you're following the techniques outlined on the current mobility guide. Be sure to maintain open communication with the physical therapist if you have any questions or concerns about the transfer techniques. Allow the patient to do as much as possible when performing a transfer to encourage their independence with all techniques. The following video will demonstrate an ambulatory transfer. Your patient will be sitting on the edge of the bed, and you'll have one hand on the back of the gait belt and one hand free to guard their upper body in case of loss of balance. You're going to have your patient lean forward to stand up, and then they'll ambulate to their chair. The patient can then turn around and reach back for their chair before sitting. I'll be demonstrating a contact guard stand pivot transfer. One hand will be on the back of the gait belt, and the other hand will be free to guard the patient's upper body in case of loss of balance. You'll have your patient lean forward to stand up, turn and pivot towards the wheelchair, and reach back for the armrest before sitting down. In the event that some physical lifting assist is needed, you can position yourself in front of the patient with your hands on the side or the back of the gait belt. You can have your patient lean forward and push off of their chair to stand up, and then they'll pivot towards the mat. And then they can reach back for the mat before sitting. We'll be demonstrating a modified stand pivot transfer with supervision. The patient has been positioned with their hips angled towards the wheelchair to decrease the distance that has to be covered during the transfer. The armrest of the wheelchair has also been removed so that the patient doesn't have to clear it during the transfer. You'll have your patient reach out to the seat of the wheelchair or to the armrest, depending on what they can reach. Their head will need to be angled towards you so that their hips will go towards the chair. In the event that your patient needs more lifting assist, you can position yourself in front of the patient with both hands on the gait belt. Your patient's head will need to come over the shoulder opposite to the transfer surface, so you'll want to position yourself to make sure that you don't prevent them from doing so. Have the patient stand and pivot to the transfer surface. We'll be demonstrating setup for a slideboard transfer. The wheelchair has been positioned at a 30-degree angle to the transfer surface to avoid transferring over the wheel. The armrest has also been removed to make the transfer easier. You'll position the sliding board under the patient by having them lean to the opposite side if they're able. You can use the patient's pant leg to assist with positioning the slide board and to avoid catching the fabric. You'll then have the patient lean back, and you want to make sure that you have about half of the sliding board under the patient and half positioned onto the wheelchair with it directed towards the center of the wheelchair. We'll now demonstrate a slideboard transfer with supervision. The slideboard has already been positioned under the patient. You'll want to cue the patient to lean forward and away from the transfer surface to make the transfer easier. This will also prevent the patient from sliding off the mat, which will happen if the patient leans back. You'll want to make sure that the patient keeps their hand flat on the slideboard during the transfer to prevent their hand from getting trapped. We'll now demonstrate the slideboard transfer. In the event that your patient needs more physical assist, you can position yourself in front of the patient to assist with the transfer. All previous techniques discussed for the slideboard transfer still apply. You'll want to cue the patient to lean their head to your opposite shoulder, and you'll want to position yourself to allow them to do so. One hand can be on the slideboard to prevent it from moving, and the opposite hand can be on the patient's hip to provide physical assist. We'll now demonstrate the transfer. In the event that the patient's hips have slid forward in the chair, you can assist them in scooting back by standing in front of the patient and blocking their knees to keep them from sliding further out of the chair. You'll want to cue the patient to lean forward towards you, and you can then grab the gait belt and have them push through their arms and legs to assist with scooting back. In the case that the patient is unable to scoot back in this fashion, you can ask for a second person to come and assist from behind to pull the gait belt backwards to assist with the hips moving to the back of the chair.
So as you've seen in this video, there are many different ways and techniques to move our residents. Some of our residents do return back to us after having a fall, having hip surgery. They might be some weight bearing, non weight bearing, total transfers. This is just to kind of give you an idea on how to do some simple, different, basic transfers. While you're on the floor, your training caregiver supervisor will further assist you on how transfers are done on the floor here at Del Monte Assisted Living and Memory Care. One of the things that we want you to remember is if you cannot safely move someone, please ask for help. Do not attempt to move somebody by yourself because you're going to potentially harm them or harm yourself. Always ask for help. Don't transfer anyone alone. Now, there are times you're going to be able to do a one-person transfer. And if you can safely do so, please do so. If you need additional training, please ask a supervisor on how to do training, how to do the transfers. And we also, as I had mentioned at the beginning of the video, do have home health come in and show us how to safely do transfers, safely have our residents use their walkers and all that fun stuff. But we're always here for any questions when it comes to safe resident transfers from bed to wheelchair, wheelchair to shower, back to wheelchair, etc. We are going to move into our final topic, principles of good nutrition. We've been mentioning this throughout the day today. Nutrition is not only good for somebody's physical well-being, but their mental well-being. It's going to help with their energy and everything. So adequate nutrition, especially in older individuals, aids in the maintenance and health and the decreasing the onset of chronic illnesses. It helps control diabetes as well. It contributes to the vitality in everyday activity, to energy, to their mood, to maintaining their independence. So if they're not getting the right nutrients, they're not going to have enough energy to do their ADLs on their own. So older adults 65 and up are more vulnerable to malnutrition and different nutritional deficiencies. So one of the things I want you guys to keep in mind when we are talking about our residents and their consumption of food, it's not always about quantity. And you're going to know who eats a lot and who doesn't eat a lot and who barely eats. But sometimes it's about the quality of the food. So if we have someone who on a consistent basis doesn't eat breakfast but eats their lunch and their dinner and only eats about 50% of that meal, we're going to want to focus on the healthier food choices. First, the proteins, the iron-rich foods, then the grains and the sweets and stuff secondary. Water. Can't say this enough. Water. Offer everybody some water at the beginning of your shift, after each meal, during the meal, before they go to bed. Water continues the main component of our bodies. Water is present in foods and drinks. The most recommended drink is water. Now, if someone's not drinking their water, we can, put different little flavors and stuff in it to help them, maybe to get them to drink their water. We really try to avoid too much teas and caffeinated drinks such as coffee because those can actually dehydrate you. But we do encourage teas and coffees, but not as the main source of fluid. And it is important for the body to also to get calcium and magnesium and fluoride. And so milk and other liquids are also recommended. Grains. The first food group from which one has to eat relatively large amounts of is grains. Now, this is for someone who is eating all their meals. If somebody's not eating a lot of their meals, I recommend that we do a protein first, because protein's one thing that we cannot substitute in a vitamin. and it helps aid in the energy as well. So we're looking for them to have, a good balance. So we do have grains, carbohydrates help fuel our bodies. So, for example, breads, noodles, potatoes, oats, corn, preferably whole wheats, and rice, and so forth. Cereals in the mornings that are high in protein are good for our residents to eat. In the grains, we're going to find a lot of the vitamins and minerals that is part of our nutrient needed for our fuel and our cells. So vegetables and fruits contain carbohydrates and sugars and waters and fibers and vitamins and other minerals. For example, vegetables and fruits rich in calcium C are cabbages and tomatoes, bell peppers, lettuce, citrus fruits, kiwis, melons, strawberries. So when we talk about, with our kitchen staff about providing a colorful plate, it's these types of food items that we're looking to give that color, that also give that vitamin C. It is recommended that they include a vegetable and a fruit of different colors at every meal. So we're not going to give them a green apple and green broccoli, right? We're going to give them a red apple and then their broccoli. Different colors on the plate will stimulate them to be hungry. Vegetables contain less sugar and calories compared to fruits. So therefore, it is recommended that they eat a 2-3 ratio of vegetables to 1/3 of fruits. So more veggies is the best route. Protein-rich foods. So this group includes meat products. This is a great source of iron for red blood cell reproduction. It's a good source of calcium, eggs, and legumes, a source of iron and calcium. This group provides different components of vitamins, zinc and B12, than other animal products. Omega-3s are in fish, and it is recommended that we eat different animal products, meat, fish, milk, and eggs, and plant-based such as lentils, beans, and hummus. And we do have vegetarians. So when we are dealing with vegetarians, we are looking to have more lentils and beans added to their diet to make up that source of that iron. It is recommended to consume low-fat cheeses, up to 5% milk, and yogurts, and 1 to 3 lean, skinless meat products. So we want them to eat low fatty meat. So we're not going to give them a steak with a bunch of fat on it or gristle on it. And then also that's not good. It's a choking hazard. So, sometimes when you get a little piece of fat in your meat, it's sometimes hard to chew apart. And if we're dealing with somebody who has got a memory impairment, they might not realize that and swallow and choke. So we want low fatty meats that are easier for them to chew. Nutrition is especially important in older adults. It's going to help keep the skin with the healing properties. It's going to encourage good blood flow when there's good nutrients going on. And so we are going to watch a quick video. What the heck?
just so important for such a variety of reasons, and these include, their skin health, preventing those pressure ulcers from ever happening in the first place, promoting good body mass, and so that with that comes those abilities to perform their functions of daily living, and maintaining their overall health and trying to prevent those serious diseases that can happen that may not be so serious for the average adult, but in the elderly population can really cause them to have a rapid decline and end up in the hospital. Extra food and fluids help to promote good skin health. A lot of times you're very concerned with skin breakdown, and of course that can result in pressure wounds, and so that requires additional calories and protein to heal those. In addition to that, it's good to have extra vitamin C and zinc, which also helps with wound healing. There's a lot of factors that play into this disease process. A lot of times there's physical and mental changes that affect them. Their metabolism has changed. They don't produce as much saliva. They don't produce as many hormones or enzymes. They also get a sense of fullness sooner than you or I would, so that they're not as hungry just naturally because of the way their physiology of their body is changing. And then, of course, the mental changes that occur that can happen to where they're not eating as well and they're refusing food. That all plays a part in, their signs of malnutrition. It's been found that in the elderly, almost all have at least one chronic disease. Many of them have two or more, and these include cardiovascular disease, diabetes, chronic lung diseases, and also, of course, dementia. So it's really important a lot of times to be careful with their diet, but at the same time you want to allow as much liberalization as possible, because restricting sodium, restricting fat is often not acceptable to the resident, and it can produce poor results because they may not eat as well if their food doesn't taste good. So it's really important to try to not be so concerned about the diet restriction, but be more concerned about just getting them to eat, period, and maintain their weight. When a person has a decreased food intake or low intake, and we usually talk about that as eating less than 50% of their meals, or if they're refusing their snacks, then that, of course, can lead to weight loss. And we know that the weight loss can be just a primary cause of malnutrition. So it's just really important to watch the amount of food an individual is taking in, to observe that, and just make sure that we're trying to get adequate food intake in with either meals or snacks to try to prevent that weight loss from actually occurring. So when we're talking about the major signs to look for malnutrition, the things you want to be really aware of is there a change in their appetite, a change in the amount of food that they're eating. Are they experiencing more weakness, more fatigue, and are they having a significant weight loss? Those are the main signs that you want to look for. We consider significant weight loss to be 5% in a month, 7.5% in 90 days, and of course if it's gone on for a longer period of time, it would be 10% in 6 months. Now in a week's time, a 2% loss is considered significant. So anytime you have that significant weight loss, there's always that concern for that person to become malnourished. So weight is a very important indicator in the progress of the disease. You might not want to weigh daily, but definitely weekly. If you're suspecting that they're losing weight, you would want to weigh weekly. So if they're losing 2% or more of their weight. And that may sound a little confusing to talk about percentages, but if a person weighed 200 pounds, for example, and the next time you weigh them, they weigh 190 pounds, so that they lost 10 pounds in that time frame. Then you would take that 10 pounds and divide it by their previous weight, which was 200. So that would give you a 5% weight loss in a month's time frame. Then that would be a significant weight loss. A person's size is not usually a very good indicator at all in dementia and Alzheimer's disease. An overweight individual can oftentimes also be malnourished or dehydrated. Swelling, or edema as it's called, can disguise an actual weight loss because of the extra fluid a person's carrying. Their weight may be the same, or it may even show that they've gained weight when in actuality they may really have lost. That's something to be very be concerned about and look out for. And it's not that necessarily it's going to harm a person, but it can make you think that they have better nutrition than they really do. And a lot of times you see that in patients who have congestive heart failure, kidney disease, cirrhosis. So if a person has those diseases, you might just be extra aware that that's a potential for that individual to have the swelling or edema. It's really a good thing to have some extra weight because we know that weight loss is usually going to occur in this disease process. So if they start out at a higher weight, then you've just got padding to kind of help you through that progression of the disease. So we don't really get so concerned about the number itself. We're more concerned about them getting good nutrition and maintaining their weight. And we know that as the disease progresses that they're going to have weight loss. And with that comes the complications of getting frailer. So it's really better if you can kind of keep, weight on the individual. The biggest change that you usually notice when a person is starting to have this decline is usually poor appetite. You'll notice that they're not eating as well as they used to. They may push food away. They may turn their head away. They just may not even have any desire to eat at all. And this is one of the biggest struggles and challenges in dealing with dementia population. So we have to get really, creative a lot of times in trying to get them to eat. I had a caregiver who took a tray into a resident multiple times with, "Here's your lunch," very excited and, very animated. This was an exciting, prospect here for this, person. And, so she was really very, very diligent in trying to present that plate over and over again to try to get that resident to eat more food. Sometimes it just takes a perseverance in making sure that you get an adequate nutrition. If a person's not eating a good amount of their meals, 50% or more, then snacks are a great way to try to increase that intake, just smaller meals per day throughout the day. So that's a good way to use snacks. And it's also good to just have them sitting out available so that the person can just come and pick them up on their own. Snacks are a great way to get in extra calories and protein. You can use peanut butter and cheese crackers. You can use half sandwiches, cookies, muffins, brownies, any kind of snack bar, popcorn, nuts, fruits. A person's executive function, and that's being able to think through what you're going to do and how the tasks are to go, how you plan out a task and order and everything. And that tends to be one of the first abilities that a person, loses even with mild dementia or struggles with, I should say. And so those can include things like the ability to be able to plan out a menu, to be able to go to the grocery store and actually purchase the food, and then to come home and put that food up, and then to be able to prepare a meal from that. So if you don't actually live with the individual and you have the opportunity to visit, that's a good thing to do, is to go and visit at a mealtime or to offer to eat a meal with the individual. And then you can actually observe whether that person is able to perform those functions that we talked about as far as the tasks that are involved in preparing a meal. And then you can also be able to observe, how well they eat and what their ability is with that function of eating and just what their meal intakes have been. It's also important, if you don't live with the individual, to frequently check their refrigerator and their cupboard, because you should be able to see that they're eating and consuming the amount of food that they should have from what was previously there. And then you can also check for expired items and look to see if anything's been spoiled, because the person with dementia may not recognize that a food is spoiled, and they may consume it without realizing that there's something wrong with it. So a lot of times it's just that observation of what's going on in their home and what's maybe different about them. You may not actually know what a person's weight is, or they may not have a scale available, but you can do just a visual look at that person and say, well, do they look thinner? Are their clothes loose on them? Are they not fitting as well as they did? That's just kind of a visual inspection. If you can also go with a person to their physician visit and just being able then to actually know what their weight is. You might see some other behavior changes. Maybe this person was always a really neat and tidy person in their home, everything was in its place. And then all of a sudden you notice that it's kind of just, there's maybe some hoarding going on, or things are just, kind of disheveled, and it's just kind of a mess in general. Like they look like they've gone to college as a young college student or something. It looks like a dorm room. Then that there's definitely a change in that person's mental status and that they need more assistance.
So the importance on nutrition is we want to maintain body weight, help the cells in the skin to be able to repair itself, and to promote energy. Sweets and other snacks always should be offered, but should be offered in a limited amount as far as cookies and cakes and stuff. We want to make sure if they're eating just a little, it's quality foods. So think of all those healthy foods in that food pyramid. So congratulations on becoming a part of the Damani Assisted Living Memory Care family. If you have any further questions, comments, concerns from any of these topics in this training, please let us know. You'll receive additional trainings on these throughout the year. And once again, congratulations and thank you for being a part of today's video training.